Since the start of the year, COVID has challenged the way we practice not only airway management, but medicine in general. It's forced us to adopt a variety of unfamiliar practices. It's been a source of anxiety and at times outright fear. But these challenges have also made us reevaluate our practice, identify deficiencies, areas of complacency, opportunities for improvement, and at times forced us to innovate in ways that might have value beyond management of the pandemic. What have we learned about managing COVID, and what have we learned from managing COVID? Wherever you're watching from, welcome to the inaugural episode of Airwaves. I'm Nick Crimes, and the topic tonight is COVID from crisis to catalyst. Welcome to the show. What we've got for you tonight is not a webinar. There's not going to be any lectures or presentations. We're going to have interviews and panel discussion with an emphasis on interaction. Interaction not just amongst our panel, but amongst the audience. We encourage you to have a conversation online using Twitter and use the hashtag AirwavesCovid. Adam Rehak is out there moderating that, and he'll be using the Airwaves Live Twitter account to do that. We also want to have interaction between our panel, but most importantly, we want to have interaction between the audience and the panel. So we've put out a survey today. A few people have answered it already, but I encourage you to go and look at it. I can't get the full URL is in the show notes, I think, or we've tweeted it out. But if you can just put that up again for a tick. If you can scan that QR code, if you've got enough different devices to scan that with your phone, that's probably the easiest way to get it. We also want you to post comments. If you're watching on YouTube or you're watching on Facebook, you can post comments there and we can put them up on the screen. So if you want to comment on what the panel is saying or ask the panel questions, do that. When the Safe Airway Society was founded, our first guest was the only choice we had to be president. John Gatwood is trained as an anaesthetist in the United Kingdom and works as an intensivist here in Sydney. He is an experienced clinician. He is an airway researcher and publisher. He is an experienced simulation educator. He was one of the authors of the COVID SAS guidelines for management of airway management in the COVID positive patient. And he joins us tonight. Before we meet John in person though, let's hear from some of the other members of the SAS board in this video to tell us a little bit what the Safe Airway Society is all about.
The Safe Airway Society, or SAS, is the interprofessional airway society for Australia and New Zealand. Our members come from a wide variety of health professions. From the outset, we've tried to include everybody that's involved in airway management, but we also represent patients and their families. And we feel like that makes us unique amongst airway societies worldwide.
There are three main reasons why SAS has been created. And in three words, that's connection, collaboration and patient safety. So in terms of connection, we recognise that within and across Australia and New Zealand we have some quite unique geographical challenges of distance and environment. What we aim to do and achieve is to connect people from all corners of Australia and New Zealand. Which leads us to the next reason being collaboration, and it's a collaboration of professions, a collaboration of skills, knowledge and expertise, collaboration in research and education, and that kind of takes us to the main reason being patient safety. So we're there primarily to promote airway management and safe practices in airway management, regardless of your profession or where you work.
Historically, airway management was really the remit of the anaesthetist, but contemporary medicine, airway management is occurring all over the hospital and pre-hospitally, so critical care clinicians are intubating patients in the intensive care unit, emergency physicians in the emergency department, and then either pre-hospital clinicians or paramedics in the pre-hospital environment. The concept of SAS is really the idea of cross-pollination and bringing the expertise from all those different interprofessional groups to promote best airway practice in all the settings that it can occur.
Overall, airway management is very safe and effective. However, there are still incidents now where patients can get seriously injured or even die. What we want to do is create an environment where safe and effective airway management is delivered to all patients. The way we're hoping to do that is to create better resources, to improve the existing systems that we've got already, and also through education and research. So we want to look at how we work as humans, as well as how we work together as a team.
A complex healthcare challenge needs an interprofessional, collaborative approach. Join us at safeairwaysociety.org.
Please welcome to Airwaves, John Gatwood. John, thanks for joining us. John's muted still, I think. And are you there?
Can you hear me now?
Yep. So off to our first technical hitch. Well done.
Yay.
How are you, John?
I'm good, thanks. It's good to be with you.
Pleasure to have you. So tell us, we saw a little bit about SAS in that video. Can you tell us a bit about why the Safe Airway Society was developed and what its mission is?
Well, our mission really is to optimise and promote safe and effective patient care. And really, it comes from an acknowledgement that multiple professions are involved in airway management now. And, you know, across Australia and New Zealand, there's people in emergency medicine, in pre-hospital medicine, who are all involved in airway management and intensive care, of course, my own specialty. And I think also we're acknowledging more and more that airway management is a team game, and it's an interprofessional sport, and we all need to collaborate together. So what SAS is about is exchanging those ideas and that expertise between and across professions. We're also about creating resources to bring that thinking together, supporting research and innovation, and promoting education through these online events such as this, but also our face-to-face meetings, which are hopefully to come in 21. Also bringing together some universal principles of airway management and translating those into clinical practice. And another thing that we're really keen to promote is and investigate further is how human factors affect airway management. And we're really proud to have 2 human factors specialists on our clinical council, in addition to a lot of human factors expertise amongst the rest of the board and clinical council. We've got 2 dedicated human factors specialists, Mick Aspinall and Brooke Dench, who have years of experience with human factors in the airline and medical industries. We're also here to collaborate with other organisations involved in airway management. We're not trying to replace any of those colleges and societies that practice airway management. We're here to augment and help collaboration between and across those organisations.
Okay, so there's, as you mentioned, there's a number of other organisations involved in airway management, both locally and internationally. So in Australia, a lot of the work has been done by the ANZCA Airway Special Interest Group, and then there's all the different colleges representing intensive care, emergency medicine, paramedicine. What's Safe Airway Society's relationship with these different organisations? You mentioned you're working collaboratively, not in competition with them. How does that work?
Well, they were involved right from the start in a stakeholder process whereby representatives from all of those colleges and societies were involved in that stakeholder process in the creation of the Safe Airway Society. So right from our inception, we've been inclusive in that regard. On our board and our clinical council, we've got representatives from all of those specialties, all of those organisations, including, and very importantly, nursing and paramedicine and anaesthetic technicians. And our membership now, we're proud to have, we're only in our first year, we've got over 300 members, and they really do reflect individuals from all of those, across the board, all of those professions. Really proud of the paramedics who are a bit overrepresented in our membership, which is fantastic. We're really pleased to see them on board. But we've got people from allied health and from surgical specialties, emergency medicine, intensive care, anaesthesia, who've all joined up. So we're really proud that we've actually become an interprofessional organisation.
So that's quite distinct from organisations like the Difficult Airway Society in the UK, Society for Airway Management in the US, the European Airway Management Society. While all of them are nominally airway rather than anaesthetic societies, and this is not a criticism of those societies at all, because of the way they've evolved, they do have an anaesthesia dominance. But it sounds like we've got a genuine sort of much more equal mix here rather than that anaesthetic dominated membership.
And yeah, I think that's correct. We'd love to have more anaesthetists join up, and we have got a good proportion, but there's always room for more, and there's lots of them. So here's a call out to anaesthetists around ANZ.
So why should people join the Safe Airway Society, John? What are they going to get out of it? I know you've managed to start a society at a very challenging time, but in some ways a fortuitous time, I guess.
Well, look, I mean, there's been good things and bad things about COVID for us, as we're going to explore today. One of the bad things, obviously, is that we haven't yet been able to have that face-to-face meeting that we're all craving, you know, getting to network with people who've got the same interests as us, getting to cross-pollinate ideas across different professions. And so what this is about, Airways, is to try and reach out to people and get them to connect. You know, when you're a membership of society, when you have a membership of a society, traditionally there's a few trappings that come with it, and we've tried to provide those in difficult circumstances. Things like a newsletter, which is delivered to the inbox of all of our members, access to all these live stream events, and in the future, when we do have a SAS meeting, which excitingly we think we might be holding a face-to-face meeting early in 2021 in the first quarter, there'll be discounts to that meeting. More financially rewarding than joining itself, so that the discount that you get will be more than the membership fee. And if you can't attend a face-to-face event, then you'll get free live streaming of that event. But the other benefit, really, Nick, it's an altruistic act joining an organisation like SAS. SAS is involved in promoting patient care, improving safety, providing resources, and a good example is the COVID-19 guidelines that we've produced. And so really, joining SAS and paying a small membership fee annually is an altruistic act and a charitable act, if you like, to help us exist. You know, all organisations, and we're a not-for-profit and soon to be a charity organisation, but all organisations have some running costs, and that's why, you know, we would appeal to people to join on that basis, on top of all the benefits that you get as a member.
Okay, so look, I think it's a great opportunity just for us to ask people out there to join the society. As John has said, there's a lot of things we're doing, even events like this, the live stream, we're putting them on, but that they do cost money, and for the society to continue to putting on these sort of events, we do need the support of that influx of finance from membership, particularly this year when we haven't been able to hold a face-to-face meeting. So if you want to engage in the society, you can see us on Twitter at Safe Airway, so follow us there. You can also follow our Facebook account, and I think the links to all of these have been pushed out on Twitter today, and also the YouTube. Follow us on YouTube, and we put out some educational videos and stream material like this as well. We'd just like to encourage you to join the society. So if you want to join the Safe Airway Society, it's safeairwaysociety.org/join. So you can go there. It's very cheap. There's discounted. There's a scaled membership, I think, for non-medical staff as well, isn't there, John?
Yes. So it's $60 for a specialist doctor, and everybody else, really, trainee doctors and all other professions, are $30 a year. And students can join for free and get all the benefits of registration of joining SAS for free. Okay,
let's get on to the COVID business. So everyone out there, as I said, this is all about engagement and interaction. So that's just our second anomaly for the night. Engagement and interaction. So as I said, I'll just put up that link to the survey again. If you get on there, we've asked you some questions that we'll be interested in. The panel will be commenting on your answers. So if you go there and fill that out, if you can scan that QR code, or I tweeted out the link, the actual link, if you just want to click on it on Twitter. So go there. It's only 5 questions. We'd be interested to see what you have to say. We can also, if you're on, as I said before, if you're on YouTube or Periscope or Facebook, you can put comments in and we'll have the opportunity to put them up on the screen. So if you want to, for the moment, just say hi to us, yell out, tell us where you're watching from, and we'll pop those comments up on the screen. But if you've got questions for the panel, put them too. But for now, it's time to meet our next guest is an anaesthetist and intensivist from Melbourne, Australia. He is the lead author of the Safe Airway Society Guidelines for COVID Management. He is an airway researcher and publisher. He's an educator, and he also once gave a presentation on his own management of an airway crisis that included the phrase, "This is an example of excellent leadership and crisis resource management." Please welcome the great David Brewster. How are you, Dave?
Good, Nick. Thanks for having me.
Good to have you.
You're doing a great job at this, mate. I think you really need to get out of theatre more, and this is a better calling for you. I think the comedy might be your
calling me a
future.
shit anaesthetist. Okay, our next guest is an emergency physician from Geelong in Victoria. She's a simulation instructor and medical educator. Please welcome Anushka Pereira. Hey, Anush, how are you?
Good. How are you? Thanks for having me.
Pleasure. And our final guest comes to us from the UK. I've got a long list of things to say about this gentleman. He is the lead author of the Difficult Airway Society Airway Guidelines for Management of the Critically Ill Patient. He's been the treasurer of the Difficult Airway Society for the last few years. He was a contributing author to both the Safe Airway Society COVID Guidelines and the UK COVID Guidelines, the consensus statement that was put out in the UK. He's a board member of the Project for Universal Management of Airways, the Universal Airway Guidelines project that I'm also working on. Please welcome Andy Higgs. Hi Andy, how are you?
I'm very well. Good evening to everyone down there. You can just about see it's light here up in the Northern Hemisphere.
Now you are coming to us from a very different perspective from us in Australia. We hit 10 days of 0 cases today. You're much more in the thick of it than we are.
Yeah, I think the end of last week we hit 168 COVID patients in the hospital. Early last week we were the 8th busiest COVID hospital. We've got about 20 in ICU at the moment.
Okay, and I did a bit of quick maths last night and worked out that your case numbers a day per capita are not much different from the US at this stage, are they?
Yeah, I mean, I've done the sort of same back of the fag packet calculations. I think we're slightly worse than US at the moment, actually, per capita.
Time to get rid of Boris.
Well, correlation, but it's a good point.
Okay, Dave, can I just chat to you? Before we go on, you put out the COVID guidelines, or the lead author of the Safe Airway Society's COVID guidelines, which were out very early. Tell us a little bit about how they came to be, and what are the main messages behind the Safe Airway Society's consensus statement for management of the patient requiring COVID precautions?
Yeah, thanks, Nick. Thinking back to March, when the COVID-19 pandemic was just starting in Europe, we were fortunate, obviously, in Australia to have a bit of lead time before it really hit our shores with the first wave, which in hindsight wasn't as big as obviously what Andy's going through now. But it allowed us time to think about how we were going to prepare. There were no international guidelines for how to manage the airway. But what we all knew was that intubation and airway management was going to be a significant risk. What we decided to do with yourself and John and Andy on the panel, with all the other authors, was to do a review of the literature mainly around the SARS epidemic some 17 years earlier and look at what we knew and really focus on how we could protect staff or look at airway management, what processes that were safe and familiar and robust that staff could perform efficiently and quickly and safely. And we felt that we only had a very short time frame to get them out. Actually, I still remember intubating my first confirmed COVID patient only a few days after the guidelines were released in preprint by the Medical Journal of Australia. We released our guidelines from memory, and Andy might correct me here, about 2 weeks or almost 2 weeks before the Difficult Airway Society guidelines were released in the UK.
Not that it's a competition.
No, I don't need to mention how many more times ours have been cited. But the interesting thing was that we released them quickly, and we needed to collaborate with all of the stakeholder groups that John was referring to. So before we put anything out, Steve McLaughlin, one of our authors, was also working with the ANZICS group on their guidelines, and the ASA were working on other documents around staff safety and PPE. So whatever we put together had to then go to the other, to both feedback from the Difficult Airway Society in the UK, as well as the ASA and ANZICS and other groups, to make sure there's going to be no confusion or any contradiction from the major parties when a flurry of guidelines were released. What we decided at the time, from reviewing the healthcare worker infections that occurred from intubation during SARS, and then some of the sketchy literature that was done afterwards, was we needed to identify what were the risky procedures, what we called at the time aerosol generating events, which have later been probably more commonly referred to as aerosol generating procedures, and what were the processes that we would employ staff, be either in paramedics, emergency rooms, intensive care departments, or the operating theatre as anaesthetists to do in order to protect them. So we thought we would champion familiar, safe, robust processes, but also look at what was considered a must-do. So a must-do was to obviously wear PPE and a minimum level of PPE, to use video laryngoscopy to maximise the distance from the airway during intubation, to avoid face mask ventilation. But the big things that we decided on were around teamwork and education. So we put together cognitive aids and checklists to allow staff to train, to allow staff to communicate effectively. We decided on what we thought were a safe number, or really a maximum number of people in the room, in a negative pressure room for all airway management. And we did this with the hope to prevent healthcare worker infection during the airway management intubation process. Looking back some 7 months later, it's pretty proud to see how what we put out then has been adopted widely in our country, and is still fairly consistent with what people are doing around the world, and obviously what Andy can talk to us about the guidelines they put out in the UK as well.
So we did have the benefit when we were writing those of liaising with Tim Cook, who gave us a look at the UK guidelines that Andy was also involved with. So there was not only collaboration going on at a local level, but internationally. A lot of people did a good job, I think, in very quickly trying to get out consistent numbers. And I think most of those have been through. I just want to bring in the rest of the panel now and ask what were the technical challenges? What were the big challenges at the beginning in terms of, because I know from my experience, we went into a period, I think everybody did, where people just started doing bizarre things. You know, people were frightened. I was frightened. I didn't realise I was frightened, I think, till the second wave came. When it started coming in with this think in the pit of my stomach, and when I recognised that, that was the first time I really realised how traumatised is overstating it, but how affected I'd been by the initial wave. And I say this as I have never, to my knowledge, laid eyes on a COVID patient. I haven't been involved in managing a whole lot of them, but just the process of training people and the anxiety and the PPE changes. What were the main technical things that people found that people were doing, and how did we bring them back? Dave, you mentioned the idea of having safe, reliable, robust, familiar techniques, which was a core of the Safe Airway Society.
We've just lost your audio there, Nick.
I think while Nick's, can you hear me, John?
Yeah, I can hear you. Yeah, I think carry on.
Yeah, while Nick's fixing his audio, I'll just butt in. One of the things I think that Nick might be alluding to is that at the time that COVID arrived, and I'm sure Nush might jump in here from an emergency medicine perspective, airway management was really changing, and it was quite a vibrant area of practice and research where things like Thrive, apneic oxygenation, use of video laryngoscopy were really taking off, say, in the last 3 to 5 years. And if you think back to when Andy wrote the critical airway guidelines with DAS 3 or 4 years earlier to where we were in 2020, things like apneic oxygenation were becoming really common. Video laryngoscopy was common, teamwork, human factors, other things such as cognitive aids were really coming in, which weren't mentioned in those previous guidelines. And I think we had to look at all of that and think which of this is safe in COVID, because some of it's become the gold standard, and particularly apneic oxygenation was one. Some people were using CPAP for pre-oxygenation in certain patients. And how did that change for the emergency department, Nush and Andy? up in the UK?
I think for us, the very first thing was just simply where are we going to potentially look after these patients in? So we needed closed rooms. We shift our thinking in terms of moving people out of the resuscitation room and into an area where we traditionally didn't intubate patients and didn't have, all our resus trolleys. So that was a complete mindset shift, which was challenging enough. And then to think about intubating a patient who was sick, who was potentially hypoxic, and then the potential of infecting staff members. So that whole psychological overlay was quite stressful. And then, yes, I think the practice of not being able to use what you might normally use was very stressful as well. We had long discussions with our anaesthetic group early on, and the plan initially was that our anaesthetists were going to do every intubation in the hospital, and they would basically create a roster whereby they had a team of people who were constantly available, who would come in and intubate anyone in any area of the hospital that needed it. And then I think it was really interesting watching to me, the whole thing's being quite poster. There was a very high stress preparation phase where everyone was getting into gear and getting things sorted, moving equipment around, creating space, preparing staff, getting checklists ready, thinking about who was going to intubate. And then we sort of dipped into this period of no one seemed to come to hospital. And all the people who were coming in with suspected COVID were actually quite well. And we started becoming inundated with patients who, where else could they be seen rather than being in the hospital? And so we had to move into finding other areas for wellish patients who needed testing to go and be seen. And so then we hit this period of, well, nothing much is happening. The numbers aren't really what they are. And we actually found ourselves in a situation where we needed to intubate some people, and we ended up intubating them in the emergency department as emergency physicians. And we had all our practices in place, but it was just interesting to watch how these plans initially started and then what actually evolved, given that our numbers were nowhere near as bad as what we were anticipating. Obviously a very different case for Andy in the UK, who would have a very different story, I'm sure.
Andy, do you want to speak to?
Yeah, I think that back in early March, I think that there were two big issues in my mind. Was A, when you intubate these patients, and B, are we all going to die when we intubate them? And I think we've largely resolved those two big ones. I think it's important because I think this discussion is still had around the world of when you actually intubate these patients. Certainly, some people, based on the Italian and the Chinese experience, were saying, some of these guys, some of these teams are intubating very, very early in order to avoid CPAP, high flow nasal oxygen, aerosol generating procedures, as people refer to them, to protect the staff. Whereas we simply realised in my hospital, and I think a lot of places in the UK, we thought we are simply not going to have the kit to do that. We have to be a bit more critical about when we intubate them. And very early on, the Intensive Care Society and the Faculty of Intensive Care Medicine in the UK put out a position statement saying that CPAP was acceptable, so you could avoid a lot of intubations. We took that view, and I think that one of the big lessons is that you intubate them when they need to be intubated, you don't take the early approach. The corollary of that is that if you wait till these patients need to be intubated, the guy on the top end really has to know what they're doing, and the whole team has to be up to, passing muster on that, because these patients will go blue on you in seconds. I intubated one on Saturday, I intubated two on Saturday, but one of them I could not pre-oxygenate beyond 93%. That was with a collapsible bag, manual PEEP, in my hands, clamped onto a face mask in someone with a little bit of ketamine, so I could get and with pressure supported breaths, and I could, for 3 minutes, and I still couldn't get the saturations up. These people go blue on you. There's a drop of a hat. The other thing I think people were.
Sorry, keep going.
The other thing that people.
I just hadn't heard my own voice for a little while, but now I'm okay again.
Well, I realize you need some supply occasionally. Now, the other thing that people were talking about is PPE, and whether or not you need full face mask, whether or not PPE and gloves was going to be good enough. And everyone remembered the plaques on the wall in Toronto General from the intensivists and the anaesthetists who died having intubated SARS 1.0, because COVID is, of course, SARS 2.0, really. And I remember intubating the first patient in my hospital and then going directly to the showers. I have never done that before. I worked out going home that night. My elderly in-laws were coming that weekend. I was thinking about scrubbing that. People were really scared, and were we going to come through this? Whereas I think that's been answered as well. PPE works. Intensivists.
Is the other thing, Andy, that a lot of the anxiety initially was driven by the stories of SARS and large anaesthetists who died. Is part of what we learned is that COVID isn't SARS?
COVID isn't SARS by any means. I mean, COVID is going to kill, obviously, a lot more people than SARS, but that's a function of its transmissibility, not its case fatality rate.
Is it in part related to how people were being intubated for SARS? Is it right to say they were at the peak of their infectivity? Whereas by the time, particularly with the strategy you're talking about of pushing intubation as late as possible, not only are you potentially gaining something for the patient, but you're inheriting that rapid desaturation you talked about, but you're maybe providing some safety because you're getting to a point where that patient is maybe not as infective. Is that part of why we're seeing a different pattern of infection with COVID compared with SARS?
I would agree with all those points. I would also add that I think that airway management, particularly in the critical, was pretty basic back in the days of the SARS emergency, and I think we have evolved very significantly. The approach to intubating critically ill patients is much more sophisticated nowadays than it was then. It's much more organized. I think if you remember from the literature of SARS epidemic, that in the first half of that period, that's when all the deaths occurred. When they got their shit together and they worked out how to do it, there were no deaths in the second half. So it's all about organization, it's all about preparation, it's all about training. Video laryngoscopes, there are lots of technical bits of kit that have evolved in the time between SARS 1 and 2, if I can put it that way. But I think it's organization, it's teamwork, and it's planning.
I think I'll just bring John in. I think you and I have spoken too about your thoughts that I think you've said a fairly limited number of publications in relation to SARS drove a lot of the anxiety in relation to COVID early on, John.
Yeah, I think there's a paper about intubation during SARS which contains 9 healthcare workers getting sick, and most of those were nurses who looked after patients before they were intubated. So, and we based our fear of intubation a lot on that kind of study, which was pretty ropey at best. So what Andy's saying about we've evolved since SARS and during SARS and after SARS, I think we've also evolved during COVID. And one of the challenges that we had early on, and especially between the first and second editions of the guidelines, was sorting what was good in this tidal wave of stuff coming towards us from what was bad. What was good? Yes, video laryngoscopy for all. Why not? Yes, maybe intubation teams, but maybe not. And depending on where you work, no intubation boxes, and the jury's out on a lot of other stuff. But face mask ventilation. We initially advocated don't do that, it's too risky, but then people just started dying of not being pre-oxygenated adequately, and then we changed that. So I think we've evolved in this short period since March, and that was one of the challenges for Dave and me. Our inboxes, we were kind of coordinating the guidelines, myself and him, and we were being flooded every day with, not just from people on the writing group, but SAS, others, lots of people opinions about how the guidelines should be changed, and trying to sort through what was good and what was bad was a big challenge.
Nush, did you...
weekend, Nick...
Sorry,
Nick, in that weekend that we were writing the guidelines, that 4 days before the MJA wanted the final version, John and I had 1,800 emails or WhatsApps about the guidelines from the writing
you're
group.
all about the stats, Krista, all about the stats. Nush, did you have that same...
I don't think we sleep.
I think a lot of us had that experience, that fear of face mask ventilation. Andy mentioned that before, that, you know, when these patients are sick, you have to mask ventilate them and you have to give them CPAP. Did your staff have that same anxiety initially that you couldn't face mask? Because I know we had a couple of cases early on where people were just letting the SATs drop to anything because they felt that face mask ventilation would be universally fatal.
Yeah, it was that real, it was that very big struggle of trying to come to terms with the potential for not being able to do what you would normally do, versus just doing it and taking the risk. And I think there were so many questions and so many decisions to make. You know, can you use a Hudson mask just at 15 litres? Do you have to have a non-rebreather? Does that cause any problems? Can you use non-invasive? If you're going to use non-invasive, where would that be? Can you use high flow? Can you use apneic oxygenation? Can you face mask ventilate? And it was just decision after decision after decision that had to go into then preparing what we would actually do if we were going to intubate someone. And I actually think that what happened a lot of the time was your just natural instinct kicked in when you were looking after these patients. And I mean, the tubes that I was involved in, thankfully weren't too unwell, and we had the way we did it was we had our checklist. We had someone standing outside the room reading every part of the checklist. There was a lot of preparation, obviously, that went on, well, as much as you can when you're intubating someone in an emergency, but very strictly following the checklist that we had both pre and post intubation to minimise the chance of there being any infection. And to be honest, that's one of the greatest things that's come out of this. We always use checklists anyway, but I think that ability to have someone outside the room or at the end of the bed actually physically reading step by step what you should be doing, it really made intubating a much smoother process, particularly in this setting. But yeah, there was so much fear about what was going to happen. It was interesting listening to Andy talk about, you know, he had intubated someone and had to go home for a shower. You know, we had people buying new shoes to wear in the emergency department so they could leave them in the office. We had people going home and having a washing machine in their garage so they could take their stuff off there and put it straight in the washing machine and have a shower outside and then go inside. And you know, it was just this real anxiety about if I've even been at work and if I've been anywhere near an airway, regardless of whether I'm intubating or not, will I carry this home to people? And then you had others like me who thought, surely it's not going to get that bad and I'm not going to carry anything home, and I don't want to bring another set of clothes to work, so I'm just going to wear my scrubs home. So it was that real struggle with what was going on and sort of denial, I suppose, as to what was happening.
So one of your emergency physician brethren in Canada, George Kovac, has gotten up very early to watch us this morning, and he's asked a question about, I think, a case that Andy had, which I was going to talk to you about now that we're talking about the psychological impact of this. Andy, you had a particularly straining episode with a patient who'd been in the ICU for a long time, and it also related to the fact that these patients are quite cognitively well in contrast to a lot of the other patients who intubate. Do you want to tell us a little bit about that? Oh, hang on, we've got no sound there. Good, I think.
Yeah, can you?
Yeah.
Am I live now?
Yeah.
Yeah. I mean, this is a patient that I think everyone on my unit remembers, a guy who was very nice guy, a very switched on guy, an engineer, PhD engineer who had returned from Wuhan actually via Jersey he lives near my hospital, and knew everything, had hundreds of contacts back in China. They were ahead of the wave with us compared to us. He knew what was going on. We kept him non-invasively intubated, non-invasively supported with CPAP and high flow for about a week. And he was desperate. One of the things that we've learned, of course, it was kind of hinted at before COVID, but one of the great intensive care lessons is self-proning. This guy was the best self-proner. He would do it for hours, completely self-starting. He didn't need to be asked. He didn't need to be shown. He did it. He did everything. He complied with the physios. He did everything he could possibly do to avoid intubation. And I remember one Tuesday night, he'd been on the cusp for a day or so, and I just said to my colleague, "We're going to have to tube this guy," and he literally begged me not to intubate him. He had a storyboard that he was writing because obviously he couldn't communicate. That mask strapped to his mouth, strapped to his face. He couldn't communicate well. But I remember the last thing he wrote was, he argued with me, begged me not to intubate him. And the last thing he wrote to try to dissuade me was, he said, "I have 2 sons, please reconsider." And I intubated that guy with tears in my eyes, and I couldn't see because you can't wipe with COVID. You just can't wipe your eyes, and I had to check the end-tidal CO2 to make sure I intubated him. I couldn't actually see the screen, and I will always remember that guy. He subsequently died. Actually, he got a lot better. Another lesson of COVID, he got a lot better. We tracheostomized him after about 11 days of intubation. He was weaning very well, and then one afternoon, over the course of 3 hours, he just died in front of us. Almost certainly a thrombotic death. He was fully anticoagulated for weeks beforehand, but still collapsed. And these patients do this. Very rarely do patients just die in front of you. Who are already fully supported in intensive care. Certainly patients who've been there for a few weeks. They rarely do that, and you see that in COVID.
So there's
seen it several times.
Yeah. So there's not only been the technical challenges, but psychological challenges. And an interrelationship between the two of them, and it's been, I think, for clinicians, it's been very challenging on lots of levels. We've talked about that from the point of view of medical staff. We also want to explore what the challenges are like for the airway assistants who work with us. So earlier this week, Adam Rehak, who's an anaesthetist in Sydney, spoke to Erin Fulsham, an anaesthetic nurse and clinical nurse educator, about the challenges that the airway assistants faced in relation to managing the COVID pandemic.
Hi Erin, thanks for joining Airwaves.
It's nice to be here, thanks Adam.
Okay, tonight we're talking about the challenges and what the pandemic has catalysed in terms of lasting change. Starting with this idea of what fears, concerns that were prevalent amongst your craft group, what was your experience?
Well, initially I found the beginning of the pandemic, it was quite a challenging time and quite a frustrating time. Everything was so new, all the concepts, procedures, PPE was just a dynamic environment to be in, because you'd turn up to work one day and they'd change something, and then another person would change something. The PPE, I feel like this was changing a lot. The order of how to don and doff was constantly changing, and quite hard to learn and quite hard to teach.
Okay, yeah, and what were the problems underlying people's ability to keep up to date with what the latest iterations of the protocol were?
Well, the nature of anaesthetic nursing is that everyone's working independently in a theatre. So to try and reach the masses is quite a hard thing to do.
It was also my sense amongst the airway assistants that there was a degree of sort of fear going around as well. Tell me about that.
We don't care for that many people with airborne precautions, let alone with all these extra precautions that go with COVID. So this was something that A, they hadn't been exposed to, and B, they hadn't had the opportunity to practice very much.
You've mentioned to me before that the complexity of the donning and the doffing and airway management protocols that were being followed contributed to the fear.
Yeah, there were a few different orders to donning and doffing that we were not used to, so that was a bit of a change, and they were a bit convoluted as well. It felt, rather than being simple.
I noticed that at times airway operators were sort of taking the law into their own hands with their own PPE and were sort of deviating from the standards that the hospital was setting. I've really always been interested in how you guys felt when that was occurring.
I think nurses that I've spoken to, it makes them feel quite uncomfortable. You know, when it did happen, it was a bit rift-inducing, I think, rather than helping us be cohesive,
So Erin, you've mentioned to me before that early on in the pandemic, this sort of decision-making and training done in silos wasn't really working well.
Yeah, so historically, most of our policies and procedure, it's all down the nursing line. And then we also had sometimes conflicting information also from, the anaesthetic side of things. They were doing their own procedure and policy, and sometimes it sort of didn't quite mesh together.
Do you think it played on the fears that we discussed earlier, feeling like it on any given day an airway operator may be just doing their own thing in terms of airway management and their approach?
Yeah, early on that was the possibility that could happen. So yeah, that could be a bit unnerving and unexpected.
Okay. So I think that echoes a lot of the issues that we've raised as medical staff, but there's something in particular I want to pick up on there and ask the panel and also the audience if this is something you experienced. Was that comment Erin made about the differential PPE between the medical and nursing staff? Because I'm also aware of this going on where an anaesthetist or an airway operator might have been in a full PAPA while someone is beside them in much lower levels, maybe still aerosol PPE, but a differential level of what was perceived as a differential level of PPE. And I think that drove a lot of anxiety. Andy, is that something you saw in the UK at all?
I have to say, not at all, actually. The level of PPE, there were a lot of concerns about this. I have to say that in my hospital, we established the standard very early, and we managed to maintain that throughout. I think there was one weekend early on when our medical director came to me and said, look, be careful with the PPE, because it was a Saturday morning. He said, we're not going to get another delivery until 5 o'clock Monday morning, and we're running low. But everyone had the same standard on my unit and in theatre. There is the differential in the UK is between the wards and the critical care environments of intensive care, the resuscitation room and theatres. And I was speaking to one of our respiratory physicians, the one respiratory physician that we have who didn't get COVID. They all got it, except him, 5 out of the 6 of them. And they use aerosol PPE when they are doing high flow or CPAP. But on the rest of the respiratory unit, they're just using PINI and disposable gloves. And goggles or visors, and I think that's shown up in the numbers. All their nursing staff have had it, all their doctors have had it, whereas in the ICU, 2 out of our 9 intensivists have had it, and about the same proportion of our ICU nurses. So I would say that that's the differential in the UK. And so that puts ICU and theatres in the safe. We're in the safe zone in many respects.
Would you say you're in the zone, Andy?
I would always struggle to use that phrase, but yeah, you could.
Get on board, baby. Get on board.
I don't know
I'm
what
sorry,
you're
I've
alluding
completely
to.
stopped conversation.
And I think that's borne out in the evidence. There's a great paper out of Birmingham from about 2.5 months ago showing that the at-risk staff are the cleaners, the ward-based nursing staff, and the acute physicians, the people who look after them on the wards. The intensivists were the index against which everyone else was measured. So, and that's, it's actually, which is safer, me getting into a Piper, little aeroplane and saying, let's go to the south coast of England, or a guy who's flown for BA, Emirates or Qantas for 20 years, taking you across the Atlantic with 500 other people. You'd have thought one is technically much more advanced and demanding, but it actually is a lot safer. And intensive care, the comparison to intensive care and the wards is similar, I think. We're doing high-end stuff, but we're doing it in the right way with the right kit.
So I think that's really, I think in some ways has our concept of, there was a big focus on aerosol generating procedures and aerosol generating events, and certainly that's important, and we're still trying to define that. But I think aerosol generation is really only the first step, isn't it? There's the aerosol generation, is the event generating aerosol, and then there's this concept of how much dose you're getting, how much aerosol was there, how much concentration you're exposed to, which is affected by your proximity to it, the duration of exposure, the ventilation. That's changed, hasn't it? And then there's the issue of infectivity. Are those aerosols actually infective in that patient at the time you're talking about? So I think we've learned there's more to it than aerosol generation. And as you say, from my mind, in theatre and ICU, and to a lesser extent, but still to some extent in ED, we've got good ventilation. We're familiar with doing sterile procedures and using PPE. On the wards, they've potentially got large numbers of COVID positive patients coughing in confined spaces with poor ventilation. We thought we were the front line, but they're the front line. And aged care is the front line.
Yeah, I mean, I think that I suppose you could think of it sort of military analogy. The airway managers are the special forces, but the people who cop for it are the poor bloody infantry out there who no one really worries about. In terms of aerosol generating procedures, you mentioned coughing. That is, if the audience wants to take away one message. If you see someone with COVID who's coughing, give them a wide berth because that, I think, is the most aerosol generating procedure there is. Spend as little time in close proximity to them as possible, and that I always worry about those patients.
Andy, I'll just go back to that previous comment, if you can, for us. What's your opinion about the use of intubation boxes and tents? And do you see any circumstances to use it, maybe pre-hospitally or during transport with non-invasive ventilation? Is there any role for these sort of barrier things? I'll come back to Brewster on this in a moment.
I think if they're well constructed for people as vertically challenged as me, they might be good to stand on. But that's about it, really. They are useless. They are dangerous, they concentrate viral load, they make airway management difficult. The one thing that COVID patients cannot tolerate is slow or poor airway management. Anything that gets between you and the patient and doing things smoothly is not in your interest or the patient's interest. Do not use them.
So they slow airway management, and also, I think we've touched on before, one of the big protections from aerosols is airflow, and they create an area of stagnant air and a awkward fomite afterwards. Brewster, very quickly, 5 main points out of your study on aerosol boxes. Go. Sorry, we've got your sound off. Oh, you've got your sound off. There you go. No, you're still muted. I'm not doing quite as well as this. This is an excellent example of crisis resource management and leadership. You're back, Brewster? No, I'll let you fiddle with it. Can I just ask a couple of things in terms of what is an aerosol generating procedure or aerosol generating event? I think high flow nasal oxygen is one that's maybe changed. John, do you want to speak to that? What's the current state of play on whether high flow oxygen is a aerosol generating procedure?
Well, look, I think the evidence is very variable on that. There's some early studies with mannequins that show it releases a plume. There's some studies in real patients that suggest it creates much less of a plume even than face mask oxygen. And there's a good study out of Australia recently with Forbes McGain's group and his intubation, his kind of bed cover that he's using there with an industrial extractor fan on it, in which they've measured particles. High flow is comparable to face mask oxygen, so a low risk aerosol generating procedure if it is at all. And it kind of confirms our biases, and thankfully, it enables us to use a treatment modality which is obviously very effective in COVID and is shown to decrease the incidence of having to intubate these patients.
I think one of the things we've learned over time is that being an aerosol physicist requires more than intuition. I think a lot of the things that we as anaesthetists and airway managers thought that we understood, we've realised we don't. I'll go to Brewster in a minute if he's got his sound back, because he gave a presentation on this at DAS, and I've seen Anil Patel talk a lot about the idea of the physics of this, that it's really about shear forces between the air liquid and the liquid interface of the mucosa. And a lot of that is about velocity of flow and viscosity of fluid, and high flow nasal oxygen isn't necessarily creating a lot of shear force. It's a high flow, but not necessarily high velocity in the airway. And my understanding, correct me if I'm wrong, Dave, is that it's not considered a particular risk, that where it needs to be used, it should be used. And there is some thought that it may even be protective by diluting the concentrations of any aerosols that do come out. Dave, do you want to speak to that? No, we've lost Dave again. Maybe Andy, do you want to respond to that?
Well, I wanted to make the point about high flow nasal oxygen is that this has been controversial in airway management, in airway management for the critically ill for some time. I mean, we mentioned it back in 2017-18 with the DAS guideline, but we hedged really. And when it came to writing the COVID guideline, there was a lot of discussion in the group about what our position should be on high flow nasal oxygen peri-intubation. And some people said, oh, look, it's not aerosol generating, we think it's safe to use. Other people said, oh, this may be a real concern. We have to hedge, we have to be careful. Whereas actually, when you come to intubate these patients, high flow nasal oxygen is very good to stave off intubation or even avoid it altogether. But when it comes to actually intubating them, the idea that apneic oxygenation keeps these people pink is for the birds, really. It's very difficult to keep these people pink with manual collapsible bags with manual PEEP valves. They will desaturate on you like a stone. And the idea that just blowing even 70 litres of oxygen up their nose will keep their alveoli oxygenated is magical thinking. So certainly in the intensive care environment, all of my patients get high flow nasal oxygen. My nurses have been exposed to millions of man and woman hours of high flow nasal oxygen, and we have low seroconversion rates. But when it comes to actually intubating them, I take off the high flow nasal oxygen because it causes a leak on the mask half the time, and that is the one thing you do not want, is a leak at any point. It's when you think about the process of airway management, the worries about high flow nasal oxygen or any form of apneic oxygenation is secondary.
But you still be advocating use of aerosol PPE for patients if you're dealing with patients on high flow nasal oxygen.
Absolutely. No, absolutely. And I have great faith in, one of the great lessons is that if you see a big third wave in Australia, is make sure that everyone is PPE trained and that you have adequate stocks.
Okay. While you're there,
and that you fit test your staff.
That's exactly where I was going to go. So fit testing is a bit of a hot potato issue in Australia. Andy, just tell us what would be the response in the UK to saying we're not fit testing?
I struggle with that concept, really. What's the point in having something that you don't fit test people on? Because you've got to keep out the badness. And I remember this from preparing for H1N1. I was actually trained 10 years ago to fit test staff for H1N1. Those skills were a bit rusty, but we did reactivate it pretty early on. That's part of the problem with the PPE supplies in the UK. It wasn't that there was a lack of FFP3 masks. It was getting the right numbers of certain types of FFP3 masks to the people who only fitted those masks. Because if there's 3 or 4 masks in use in your hospital, you may fail with 2 of them, and it's the other one that you need. And so the stock levels have got to be controlled quite well. The NHS is very good at its logistics generally, but it tends to monitor. It's all done electronically, so often the central stores will send out what they think you need rather than what you seem to be lacking on the ground. So it takes a bit of sophistication there. But you have to fit test. I can't see a reason why not. Because
making that happen, though, from the way you're describing it, sounds like this is not a matter of just getting someone in to fit test your staff and go. This is something you've got to embed in the hospital as a sustainable, perpetual process as stocks change, as staff change.
Yeah, it will take 2 or 3 weeks to get all your staff, because all your staff aren't in at any one moment in time. You have to chase them up. You have to have a list of who's tested on what mask, and you have to make sure they attend for the fit test. It's quite a big operation, and it's not for the faint-hearted. Actually, all of our fit testers.
We mentioned the risks to ward staff. Would your ward staff be in aerosol PPE with those coughing patients before ventilation?
No, that's that I think is the blind spots in terms of PPE, because on our intensive care units, everyone is PPE'd up to the eyeballs at all times. On the respiratory unit, when they're using high flow or CPAP or NIV for the bronchitic, they get aerosol level PPE. Other than that, it's pinny disposable gloves, and a surgical face mask.
So we're left with a bit of a contradiction here, isn't it? We all agree that the real risk is on the wards and in the aged care centres, but we're taking all the PPE. Have we got to shift our thinking? And I think this is a legitimate, I'm not saying it's a necessarily justifies a barrier, but I think it is a legitimate logistic problem for hospitals trying to implement fit testing because of the amount of PPE it potentially consumes. That if you do it, and we've already talked about the differential PPE between airway operator and airway assistant. If we start pushing that at a ward level, and they're not getting it, but we think they're at risk, how do we logistically implement that? I might leave Andy for a moment. I'll just Nush and just ask what fit testing and John after that what fit testing is like for you, and then I do have another question for you, Brewster. Get your microphone going. Get poised, baby.
It's working.
Nush, excellent, Nush.
So the interesting thing is that we've had different types of N95 masks that we've been given, and so each time you have to put one of those on, you obviously have to check that that one has a seal. We haven't done formal fit testing in our department, but we have been taught how to ensure a good seal, and so we check each other when we put N95 masks on. An interesting thing that a lot of female doctors have mentioned is that the shape and size of the mask is hard to fit on their faces, just being naturally a bit smaller. And it's been really hard to actually get a seal for a lot of people, which also then does way into just thinking about PPE in general and sizing of gowns and gloves and everything to make sure that you can actually still do your job with your PPE. So the whole PPE issue is quite interesting. But yeah, mask fitting is an issue, especially when you're changing different brands and types of masks on a near daily basis, simply for supply issues.
Okay, I'm gonna move us along because we're way past time here. One of the things we also want to deal with is the issues of PPE in the pre-hospital setting. So Matt Humar is a Victorian paramedic, and he spoke last week to Alan Eade, who's the Chief Paramedic Officer for Safer Care Victoria. Let's hear what they had to say about the challenges of the COVID pandemic in the pre-hospital setting.
Thanks, Nick. I'm here with Alan Eade to discuss some of the broader challenges and changes that occurred with the pre-hospital care during the course of the pandemic. Alan, thanks so much for taking the time to join us.
For having me. It's a pleasure to be here.
Alan, you work both as a practicing intensive care paramedic, a MICA paramedic with Ambulance Victoria, so you've attended to patients with COVID or suspected COVID, and you also work as the Chief Paramedic Officer. So you have some insight about some of the things that happen behind the scenes in terms of pre-hospital care. So we want to tap into both of those roles and experiences. And our first question is, what have been the most significant challenges specific to airway management over the course of the pandemic?
I think all clinicians, particularly out of hospital, the overwhelming fear and anxiety has been related to the infection risk. Am I going to get the infection? Personally, I thought I'd be okay if I got the infection, naively at the very beginning. But I was very worried about whether I would take the infection home and bring the risk home. So we did a lot of work very early on around going home safely. But associated with that, and specific to airway management, as you were saying, the Safe Airway Society guidelines that came out very, very early on in the pandemic were world leading, and implementing guideline adjustments for the out-of-hospital providers around aerosol generating procedures was one of the very early steps that was taken to try and prevent and reduce the impact of the infection risk on the providers themselves and them taking it home. I think that the other aspect that has really been present throughout the pandemic has been the perception of the adequacy of the care we're providing, or the safety of the care that we've been providing. And there's a lot of discussion now in the literature around moral injury, and I think this is going to be the thing that hangs around for a long period of time. This will be the long COVID tail for the workforce. We changed our access to healthcare. We changed the outcomes that we're seeing from our healthcare. There's published outcomes in cardiac arrest which show a halving of outcome. The indirect impacts of COVID on slowing our systems and our processes of care. The impact on not just the patient but their family, lack of visitors, inability to support people to health services, and the communication challenges that come with PPE. They can't see you cry, they can't see you smile, you're stuck behind a mask. It's been very, very difficult to show and display empathy. The last part is around communication in broader terms across the health sector. Multiple guideline changes, seemingly endless guideline changes at some points, ever-changing PPE guidance from an ever-increasing number of people that want to have an opinion, and then a focus on PPE to the exclusion of all other aspects of safety, so physical distancing and appropriate hand hygiene. We don't have negative pressure rooms in the pre-hospital space, but we do have wide open spaces. Using those really sensibly and logically and pragmatically is actually one of the keys to providing safe care.
Thanks, Alan, and no doubt those challenges have been quite consistent across Australia and perhaps the world. For our second question, we want to change tack slightly and ask you about some of the benefits that COVID-19 has brought with it. So in your experiences, once again, in your various roles, what have been some of the changes that have benefited patient care or the practitioner, and which of these are likely to remain into the future, even once the pandemic subsides?
There's been many things that are actually good that have come out of COVID. I think infection prevention and control is the overarching one that will remain. The paramedic profession has traditionally been rubbish at infection prevention control, but transmission-based precautions and effective hand hygiene, these are things which are just going to be now, thankfully, and well overdue, commonplace going into the future. I think that the concept of what is an aerosol generating behaviour on top of an aerosol generating procedure, and the fact that we need to take adequate precautions associated with those, that'll be the big thing which remains. That'll be the language which we take forward. It'll also be the change that we see. You will not see people in the out-of-hospital space intubating the patient with an unknown history without facial and eye protection into the future. It will look as weird as it does today for you seeing somebody try and cannulate without wearing gloves. And I think that's a real positive for us going forward.
Yeah, couldn't agree more. Alan, that's all we've got time for. Thank you so much again for taking the time to talk to us, and thank you for all the work you've done and continue to do in this space. It doesn't go unnoticed.
Thanks, Matt. I actually think that the credit goes to the clinicians that are out providing healthcare, no matter where it is, whichever environment, whether it's in hospital, out of hospital, the retrieval services if you're in ambulance or transport or in any other factor. The people who've been doing it hard are the clinicians. They deserve our respect because they've been amazing.
Okay, thank you very much for Matt and to Alan for joining us for that. I just need to plot a way out of this because we're way over time. So what I want to do is look at the survey results. And Brewster, then I'm going to come to you and just get you to talk to us about, just sum up, what is best practice now? What have we learned? What do we think is best practice? But first, let's look at the survey and just see what the audience thinks is best practice. So the question we've asked here is, which of the following do you consider to be key components of airway management for patients requiring COVID precautions? So 80% for video laryngoscope, 70% for rapid onset neuromuscular blocker, 70% for checklist, 65% for negative pressure ventilated room, 50% for a room rest time before other staff without aerosol PPE enter the room, two-handed grip, avoidance of face mask, vice grip, scalpel technique for neck rescue, second generation device for a supraglottic airway, so we're now in the 30%, high air change rate room, 30%. I'm surprised that a high air change rate room rates well below a negative pressure room. We might get Dave to speak to the relative benefits of air change versus negative pressure. Rock over sucks, indirect view when using the video laryngoscope, ketamine to propofol, intubation boxes only 15%, covering the patient with a plastic sheet 10%. No one thinks that a PAPR is a necessary thing, and I think there was a good study came out of, I think, the Austin and from Andrew Silvers also at Monash, showing that PAPR didn't change infection rates at all, but made communication a lot more difficult, but people were a bit more comfortable. Dave, looking at that, I will just whiz through, we'll see what else there is. So these next thing was things people have concerns about. So not many people concerned about those things that I think early on there was a lot of anxiety about doing all of those things, and we've talked about a bit about those already. We'll keep scrolling down there. And so this was just to find out, we talked a bit about desaturation. So most people, there a bit of a wide split there. So most people would avoid performing face mask ventilation unless severe or prolonged desaturation occurred. Only 30%, but a lot of people not ventilating up front. And we might come to Andy and again just reinforce his thoughts. I know we've talked a bit about the need for ventilation. We'll just scroll down a bit more. I think there's only one more question, is there? Let's skip that because it's a bit niche. Significant benefits arising from the COVID pandemic. We'll come back to that. Brewster, you've seen what the audience thinks. Can you just sum up for us very quickly what you think you talked early on about the musts. What are the musts for airway management in a COVID patient?
Look, I think from our experience in Melbourne, which would be 90% of Australia probably, a lot less than Andy in the UK, but our experience would be preparation and training is a must. I think if hospitals don't have good education practices now, don't have staff that are well prepared, both with the use of PPE and the process of airway management, and they don't have the right equipment and the right room, video laryngoscopy, the right drugs available, cognitive aids checklist, then they're not going to perform well. So I think education and preparation is probably the must. I think that having the best clinician assigned to the task of intubating is a must. I agree with Andy. These patients desaturate rapidly. They often don't last anywhere near the 60 seconds of apnea from when the rocuronium goes in. The saturations can plummet almost instantaneously, as has been alluded to tonight. So you need to have someone most skilled at putting the tube in. And I think a must would be the use of video laryngoscopy. I don't see a negative in its use. And a must would be rocuronium, high dose. So you want paralysis quickly. And I think that probably people have got a little bit distracted by aerosol generation, be it high flow nasal oxygen and CPAP along the way. And I know, as you alluded, I spoke at the DAS conference with Kareem and others about this recently. The biggest risk to me is still all of the routes of transmission and the amount of contact that you have, close contact with the patient, and as you've all mentioned, the ward staff. So I think that having people trusting their robust, reliable processes is still important, rather than being overly frightened of as you mentioned before, overly frightened of one or two particular things, such as face mask ventilation. So if a patient's desaturating, don't let the sats drop to 50. If they need gentle face mask saturation before the paralysis works, you need to do that, because sticking the laryngoscope in early and allowing them to cough is much worse.
Yep. I suppose implicit in what you're saying there is also don't just fixate on the aerosol generation procedures. Remember the fomites and the droplet spread. Yep. Get the basics right. You know, if you get the basics right, that's probably 90% of it is there. And we've really focused on something not that we should ignore, but maybe isn't the major issue, particularly for us in theatre. Andy, can I just come back to you? Brewster said there about ventilating. You and I have talked about this a bit. What would you advise to people as the trigger for face mask ventilation in intubating a known COVID patient for respiratory failure? Sorry, we've got sound. You're on. Go.
I think that if you're going to not intubate them early, and you're going to try to avoid intubation, they're going to be very sick by the time you actually put the tube in. I prophylactically manually ventilate them with a collapsible bag. I think, again, COVID has answered, to my mind, one of the debates that airway managers have of self-inflating bags and collapsible bags. How on earth do you know you haven't got a leak unless you've got a collapsible bag? And that will tell you about the compliance of the lungs. It will tell you whether or not you've got a leak. I actually I prophylactically ventilate them, and in terms of the team management, I tell my first assistant, the one who would usually, the person who's about to do cricoid, I say, make sure that there is no leak on the mask. In other words, hunker up the cheeks into the mask during pre-oxygenation and after induction. And I would much rather, I'm a great advocate for cricoid pressure, but we've had that debate several times. But if there's a choice in COVID between using cricoid pressure and having my assistant make sure there's no face mask leak during pre-oxygenation and after induction, there's no contest. They have to help me avoid the leak.
So I'll just pick up on something you say. Has COVID resolved every controversial conference airway debate? VL versus DL. VL's in. Sucks versus Rock. It's Rock. Checklists are in. Cricoid's out. Cannulas out. Scalpel's in. Is it the case that putting anaesthetists in the situation where suddenly our life was on the line too, maybe, made us stop debating all this nuanced stuff and just think, hang on, let's just get down to it. I'm going to make a decision.
Well, yes, and also the fact that COVID patients separate, in terms of airway management, they separate the sheep from the goats. These patients will not tolerate bad airway management. And so when you've got to get all your ducks in a row, you go for your video laryngoscope, you pre-oxygenate them well, you have your checklist, and you're ready with a scalpel bougie tube if it all goes wrong. So, yeah.
I know your bias is on scalpel bougie. I still maintain there's a place for cannula. But I want to pivot now.
Really?
Calm, everyone, calm. Let's just we'll just wrap up quickly now. I'll just go to on that basis. What are the advantages? What are the benefits that come out of COVID? I wanted to talk a bit more about this, but maybe we can have a future meeting on this in itself. This is what the audience has said. 65% agree virtual meetings and conferences improve collaboration between disciplines. We've got nearly 50% have improved access to video laryngoscopes, increased use of video laryngoscopy, and then checklists, pre-briefs. I think Erin mentioned in her video about the use of pre-briefs and things. Cognitive aids. Okay, so I'll just go around the panel and get you to say what do you think, because we've got to move on. What do you think is the main thing you think has come out of the pandemic? Things that we have had to rethink, that you think this is something we need to capture and take forwards, and this has benefits beyond the management of COVID. And I'll put my hat into the ring. For us, I think it was the relationship between the different departments. So all the airway management departments, ED, anaesthetics, ICU, we now work in a much more integrated way. We've got a consistent checklist. We've got clear lines of communication. And we're doing now things, we're doing interdisciplinary training and stuff in a way that we weren't before. And that's something I've longed to get going, and COVID made it happen. So that's been a real benefit for me. John, what has it been for you?
I'd echo the stuff on interdepartmental cooperation. We had way more of that than we've ever had before. A friend of mine, Chris Hicks, once said there's nothing like being in a crashing aircraft to suddenly become interested in aircraft safety. And we've seen an almost universal adoption of guidelines, cognitive aids and checklists. And Brewster and I and a few others from ANZICS have surveyed a bunch of intensive care units, and we were really, really pleased to see that people are using cognitive aids, checklists and guidelines almost universally. And as a simulation educator, also really happy to report that almost everybody was doing interprofessional simulation-based training to really get their COVID intubation and airway management strategies down pat, and that's definitely something we should be taking forward for non-COVID patients and COVID patients alike.
Thanks, John. Nush, what are the main takeaways for you? What are the benefits, the things you want to keep from COVID?
I think some of the things we've done is the way we disseminate information amongst a very big group of staff who are continuing to move and shift through their rotating rosters. So we now have a pre-shift briefing where we update staff and check in on how they're going prior to all 3 medical staff shifts every day. Definitely the much more mandatory use of checklists, which a lot of us were using anyway, but now has become quite it's just become a must-do. Our PPE use has obviously been massively improved, and people have really nailed that, which is really good. And I think that in general, just in terms of staff looking after themselves, there's a bit more acceptance of, if you're feeling unwell, you should actually stay at home and don't come to work if you're sick. I think one thing that the pandemic we could have had the opportunity to do a bit more is look at bolstering some of our community health services and fixing up what's going on in our residential aged care facilities. And I think if anything should come out of this, we really need to look at how we fix up what's going on in the community, so that hospitals can get on with dealing with the really, really sick people, and those who need semi-urgent and not urgent care can actually get their care in the community. So that's probably the next step I would be looking at.
So Brewster, I'll come to you. Double barrel question. What are the main things you want to keep, and where to from here? You know, we're down to 0 cases now. Things are looking good. How do we get ourselves lined up so if there's another surge, what do we need to do? And I'll ask the same question to you in a moment, Andy. Where to from here from you from a very different perspective of going into a busy winter? Dave?
I spoke about this a little bit the other week for Andy in the UK. I think the real risk with a third wave is the ward staff, and I feel like there's been a lot of focus on aerosol generation and airway management, but the real focus needs to be on educating and protecting the staff on the wards. If they had the same level of education and equipment that we'd had, then in Victoria we wouldn't have had 3,500 healthcare workers infected. And I think that going forward that we really need to take a good look at who are the most vulnerable healthcare workers and how we can protect them better. That's my personal take. What from COVID have we learnt going forward? Someone mentioned before, I think in Matt's interview, the ever-changing guidelines that's come out of the government. Every few days they change their opinion on PPE and everything else, whereas you know, our airway guidelines and those in the UK haven't really changed since we put them out. There was a couple of changes in the first week and then they've stayed the same, and having processes that are consistent, that staff understand, that don't change every week, minimises confusion. So one of the things I think, if you're going to put something out, get it right, get it out, do it properly, and then cognitive aids, checklists, these things can be locally adapted by institutions, but get the crux of it correct the first time. And I think that's one of the challenges for Puma, which you're all going through now. And some of the stuff that you're putting together looks fantastic, but that's the real challenge. If we're going to put guidelines out, make sure that they are right from the start.
Yeah, I think that's definitely true, but at the same time, I think we have to acknowledge there have been real challenges in doing that with the rapidly changing information and different. You know, I was talking to Nush yesterday about just people taking the go-getters who wanted to do stuff, but they would go and do stuff in a bubble. Nush, and then someone else was
or a box. Some of them were doing it in an aerosol box. Yeah.
Well, there was such an overload of information that was coming from everywhere. Everyone had an opinion, and you didn't really know who to trust. And so I can't imagine being in the situation of being the person who was deciding this is the PPE you need to wear today, and then 2 days later finding out you need to upgrade it or downgrade it.
I think one of the things we're seeing change. I think one of the things we're seeing change now in studies like the Jules Brown study out of Bristol and the one at St V's is that we're involving, you know, people with, you know, chemistry, aerosol physics knowledge in these studies of aerosol generating procedures rather than just doing it ourselves. And we really need to have, you know, the airway management and the infectious disease people and the people who understand the physics of all this collaborating in future studies to get the right answers. And I think that's starting to happen. Andy, I'll come to you just to finish off. What do you think are what's your takeaway thing that you think is a real benefit that's come out, that we're going to come out the other side of COVID and think, well, that was a good thing that happened out of it? And where to for hear from you in the UK with the surge in winter?
Look, you really want to depress me asking that question, don't you?
George there is talking about his goatee, the facial hair of choice.
Yeah, I'm going. Yeah, absolutely. Keep it short, keep it tight. You know, that's always important, and make sure the mask comes underneath. But in terms of airway management, everyone's mentioned checklists, but you just have to make sure that everyone on your team knows what this intubation should look like before you start, because even when I'm doing my ward rounds, even when I'm standing right next to the nurse looking at the chart and looking at the patient, we can't hear each other. The idea that you're going to communicate effectively with a patient whose saturation is 60%, with oxygen flowing, with everyone in PPE, with echoes in a room, it just doesn't happen. You have to know what you're going to be doing before you start. So it has to be highly sterilized according to the checklist. I think another thing I would say that all the guidelines mention, but people very rarely talk about, and people very rarely do, is after you put the tube in, perform a recruitment maneuver if the hemodynamics will tolerate it, because they have, sure as eggs is eggs, de-recruited during the airway management, and so they're going to be worse than when you started. I mean, it's amazing how often our patients are being proned within an hour of intubation, because they are that sick. Going forward, I think that it's not particularly airway management, but I think how you escalate in a crisis. We are now at 150%. We're operating at 150% of our critical care, normal critical care maximum capacity. So you have to bring in other staff members. It's about giving them the training they need and the confidence that they need to to flex up during a crisis. And that's a major problem, because I want PPE, but more than anything right now, my unit needs ICU nurses.
Okay, thanks for that, Andy. We are half an hour over, so I'm going to call it stumps. Thank you very much to our panel for joining us. We will put up on the Safe Airway Society website at safeairwaysociety.org/airwaves. I'll get the panel to put out there what they think are the key references for COVID airway management, and we'll put them all on there. They're not on there now. We'll put them up tomorrow. So safeairwaysociety.org/airwaves, and go to episode 1 at the link there, and we'll put the resources up there. We've already planned our next episode. It won't be till January next year. The topic will be video laryngoscopy, and joining us will be Tim Cook, author of all the naps thus far, and the most published airway author on the face of the planet. So we're very glad to have Tim along. George Kovac will also be joining us, emergency physician from Canada, who many of you will know. And Richard Cooper is going to give us some lessons on the technique of video laryngoscopy. So we're going to talk about all aspects of video laryngoscopy, and that will probably be in late January next year. I'd like to encourage everyone out there to please join the Safe Airway Society. It's not much money, and it supports events like this and other events going forwards, the guidelines, other educational programs, and we really just need a bit of support to make sure that we can keep delivering this for you. I think you've seen tonight that we've got quite a unique society that engages a lot of different clinicians, both airway operators and assistants across from multiple backgrounds. Thank you very much for joining us, everyone. I hope you've enjoyed the show. Continue the conversation with our panel on Twitter. You've seen their handles up during the show. Thanks very much, and we'll see you next time on Airwaves.